A very good afternoon and welcome to the first exclusive webinar on Fujifilm Wako Hepatocellular Carcinoma Biomarkers. I'm Yi Peng, your MC for today's event, hosted by Malaysian Society Gastroenterology and Hepatology, MSGH, Pantai Premier Pathology, Fujifilm Wako, and Chemopharm. This event is exclusively brought to you live from Kuala Lumpur and Osaka, Japan. Thank you for joining us today, and we do hope that everyone will stay online with us right till the end. The theme for today's webinar is Introductions of Hepatocellular Carcinoma Biomarkers and the Clinical Utilities. Before we begin our webinar session, let's have a quick rundown on today's program. We will start off with Professor Afendi Raja Ali, the President of MSGH, to deliver an opening speech. There are two interesting topics which will be delivered by distinguished speaker Dr. Tan Sok Siam from Malaysia and Dr. Hiroyuki Yamada from Japan. In order to make this event run smoothly, we do hope everyone will adhere to the housekeeping message shown here. Please ensure that your microphone is muted at all times during the webinar. On the session's begin, you may post your questions by clicking the Q&A box on your screen. Please do not forget to state your name, country in the Q&A window along with your questions. The speaker will then respond to as many questions as possible during the Q&A session right after the industrial talk. It's my great pleasure to invite the President of MSGH, Professor Dr. Raja Afendi Raja Ali, to deliver an opening speech. Ladies and gentlemen, please welcome Professor Afendi. Raja Afendi Raja Ali is a professor, Dean of Medicine and consultant gastroenterologist at the Faculty of Medicine, the National University of Malaysia. Currently, he is the President of Malaysia Society of Gastroenterology and Hepatology and the Congress President for the Asia Pacific Digestive Week 2021 in Kuala Lumpur. He is a Fellow of American Gastroenterological Association and the Royal College of Physicians of Edinburgh. Without further ado, I will now pass over to our Chairman and Moderator, Professor Dr. Raja Afendi Raja Ali, for the opening speech. Over to you, Prof. Afendi.
Thank you, Yi Peng, and a very good afternoon to all. It's a great honor and pleasure to be a moderator for the very important topic. On behalf of the Malaysian Society of Gastroenterology and Hepatology, with the webinar that we have today, Fujifilm Wako, on the discussing is about hepatocellular carcinoma from the clinical diagnosis, epidemiology, and surveillance status, as well as very important the use of biomarkers. We have a very good, we have outstanding two speakers today, and on behalf of the MSGH, I would like to thank Fujifilm, Chemopharm, Premier Pathology Lab, as well as Wako for participate in the webinar today, which is very important to all of us as a clinician, whether we practice in Asia Pacific region or beyond, about the hepatocellular carcinoma. Again, we have two outstanding speakers, and we have the Q&A session for all of you to ask the panels about your queries with regard to the HCC. And then I think the first one, we're going to go to the first speaker, which is Dr. Tan Sok Siam. So the first speaker is no other than a very experienced and outstanding clinical hepatologist from Selayang Hospital in Malaysia. She's obtained her primary and secondary degree from Republic of Ireland, and is a well-known hepatologist in the country and the region on Asia Pacific, participate as a speaker in many national and international meetings. She's actually a past president of the Malaysian Society of Gastroenterology and Hepatology, and also a very important holding the position, for example, the Fellow of Academy of Medicine of Malaysia. She's a very active member of APAZL, and of course regularly involved in the not only at the regional or Asia Pacific meeting as well as European and US meeting with regards to liver cancer. So today we are grateful to have Dr. Tan Sok Siam, and she's going to discuss with us about the clinical epidemiology and the current status of hepatocellular carcinoma, as well as surveillance and in the arena of this cancer. So without further ado, I would like to invite Dr. Tan Sok Siam, and the stage is yours.
Thank you, Professor Afendi, for the very kind introduction. I hope you can all hear me.
Yes, go ahead, proceed.
Thank you. First of all, before I begin, I would like to also thank Fujifilm for inviting me to present in this webinar. So good afternoon, ladies and gentlemen. And the topic given to me is on a hepatocellular carcinoma. And this is with respect to the epidemiology of hepatocellular carcinoma. I will present to you some data of the global epidemiology and also the local epidemiology. And also been asked to talk about HCC surveillance. What is the current practice in my hospital? And I will end with some recommendation from the APASO COVID-19 Task Force on HCC surveillance. HCC is the fourth most common cause of cancer-related death worldwide. This slide shows the global burden of primary liver cancer. Of the primary liver cancer, 80 to 90% of them are due to hepatocellular carcinoma. 85% of HCC are actually found in low and middle resource countries. In actual fact, the incidence of HCC is highest in the sub-Saharan Africa and East Asia. In terms of the global distribution of HCC, the incidence are high in same areas for males and females. Chronic hepatitis B and chronic hepatitis C are the most important causes of HCC. Both of them together make up 80% of the causes of HCC. The annual incidence of HCC is about 2 to 5% in cirrhosis patients due to chronic viral hepatitis. In endemic areas with hepatitis B, 30 to 50% of the HCC can occur in hepatitis B patients without evidence of liver cirrhosis. The age of diagnosis of HCC is very young in Africa, at about 30 to 40 years old. In China and South Korea, it is a bit older at 50 years old. In Japan, Europe, and North America, the age of diagnosis for HCC is about 60 years old. The causes of HCC in Asia Pacific countries are mainly due to hepatitis B, except for Japan, which is due to hepatitis C. Based on literature published in 2000 to 2013, you can see more than 60% of the HCC are due to hepatitis B, except for Japan in all the countries in Asia Pacific regions. We all know that antiviral therapy with NUC and DAA can modify these risk factors for hepatitis, for liver cancer by treating hepatitis B and hepatitis C. However, in order to see a reduction in HCC from these two very common risk factors for HCC, we need to scale up the diagnosis, link to care, and also treat many patients to see a decrease in HCC. This slide shows the burden of liver cancers in 2018. In terms of incidence, the total number for 2018 was more than 841,000. In terms of mortality, it was more than 781,000. Asia suffers the most, and you can see Asia contributes to 72.5% of liver cancer in terms of incidence and 72.4% in terms of mortality. Looking at the incidence and mortality by cancer sites from Global Scan 2018 for Malaysia, you can see liver cancer ranked number 6, giving a new cases of 1,944 in the year 2018, and it ranked number 4 in terms of death causing death in 1,933 people. For the Philippines, Global Scan 2018 showed liver cancer ranked number 4 with more number of cases at 9,628 of liver cancer in the year 2018. And in terms of death, it ranked number 2 with a number of 9,485 cases death from liver cancer in the year 2018. This slide shows liver cancer, hepatocellular carcinoma between 1987 to 2008 in the northeast region of Peninsular Malaysia. They studied a series more than 250 HCC. You can see there's a preponderance of male with male to female ratio at 3.7 to 1. 85% of them are older than 40 years old. Hepatitis B predominant at about 60%. Hepatitis C was 2.4%. Majority of these patients have very high alpha-fetoprotein. Only a small number of these patients managed to have treatment with surgery. And of course, the survival is very poor. At 6 months, it's at 23%, 1 year, 13%, and 2 years, 7%. Another series, also around 2006 to 2009, in an institute in the central region of Peninsular Malaysia. They studied 348 patients. The male to female ratios is 3.4 to 1. The median age group of HCC was 62 years old, and majority are due to hepatitis B, more than 60%. And this series shows cryptogenic liver cirrhosis can cause HCC at 29% and Hep C 18.3%. The median alpha-fetoprotein, the median alpha-fetoprotein in this series is 200, and by BCLC stage A, it was found in 34%, stage B 21%, stage C 24%, and stage D 20%. In this series, more patients were amenable to curative therapy. 10.4% of them were amenable to liver resection, radiofrequency ablation in 22.9%, TACE in 14%, but still 41% were only possible to be managed as palliation and other therapy, and chemotherapy was only 0.3%. Metabolic dysfunction associated fatty liver disease, the new name for non-alcoholic fatty liver disease, is a major cause of chronic liver disease in Asia. Overall, the prevalence in Asia is 29.62%. You can see in Malaysia, the prevalence is very high at 38.5%. In the Philippines, it's lower, between 20 to 25%. The annual incidence of HCC from metabolic associated fatty liver disease is 1.8 cases per 1,000 person years. And it is the fastest growing cause of HCC related transplant in the US. So metabolic associated fatty liver disease related HCC is expected to increase in Asian populations. There are global variations in mortality from liver cancer, as you can see in this slide. This is due to the differences in timing and level of exposure to the risk factors, the healthcare resources in the various countries, the ability to detect HCC early, and also to provide curative treatment in those various countries. This is a study in my hospital. HCC increases the direct cost for management of hepatitis C patient in my hospital. Based on values in 2018, the annual cost in ringgit Malaysia, as you can see, if there is HCC, it can increase by 10-fold. And if there is HCC and decompensated cirrhosis, it can increase even higher by 40-fold compared to a patient without HCC. The overall survival of patients with HCC also varies. In countries like Egypt and other African countries, the survival time rate is very poor at a median survival of 3 to 11 months. Taiwan and Japan have the best clinical outcomes. In Japan, the median survival from the time of treatment initiation for HCC is 60 months. This is due to the high proportion of HCC detected at an early stage from nationwide intensive surveillance programs, which Dr. Hiro, the next speaker, will share with you. HCC surveillance allows early detection of HCC, and this allows increased chance of curative treatment. For example, if patients are diagnosed at BCLC stage 0 and A, patients can have liver resection, radiofrequency ablation, or liver transplantation. HCC treatment modalities are influenced heavily by the liver function, the Child-Pugh score. Has a patient got Child-Pugh score A, or is it between A or B, or already severe decomposite with Child-Pugh score C, whereby not much can be done. It's also influenced by the tumor burden. Does the patient have single tumor, small size, less than 2 centimeters, or more than 1, 2 to 3 nodules, but still small size, less than 3 centimeters, or the patients have multinodular cancer, or even worse, if they have portal vein invasions and other extrahepatic metastasis. Also very important is the portal hypertension. This will influence whether the surgeon can go and resect the liver tumor. And also very important is, of course, the performance status of the person who has HCC. A patient with Barcelona stage 0 with single lesion less than 2 centimeters, Child-Pugh score A, and ECOG 0 to 1 are amenable to liver resection or radiofrequency ablation with very good results. A patient with Barcelona stage A with single or 2 to 3 nodules less than 3 centimeters and good performance status and still preserve liver function can also still go for liver resection or RFA or also liver transplantation. For BCLC stage B, multinodular disease, if the liver function is still preserved, the patient can be treated with TACE or downsized for liver transplantation. When the patient has stage C, BCLC stage C, when there is portal vein invasions or extrahepatic disease, we are talking about systemic chemotherapy. And in the patient with stage D, BCLC stage D, poor liver function is actually best supportive care is the only amenable treatment. So HCC surveillance, what do I do in our hospital? We do alpha-fetoprotein and ultrasound every 6 months. But in clinical practice, it actually takes more than 6 months to get an ultrasound appointment. And the indications for HCC surveillance in my hospitals are chronic hepatitis B patient over 40 years old in males, over 50 years in females, if there is a family history of HCC, or any patients with cirrhosis, unless the patient have Child-Pugh score C and without an option for liver transplant, whereby a diagnosis of HCC actually means there's no other suitable HCC management. In this time of COVID-19 pandemic, we adopt the new normal. HCC surveillance is also affected by this new normal. So the APASO COVID-19 task force recommended that although HCC surveillance with ultrasound alpha-fetoprotein every 6 months is recommended, there should be a balance between the risk of delayed HCC detection and the risk of spreading COVID-19 during the process of HCC surveillance. So the task force recommended that for HCC surveillance, we should continue surveillance in high-risk patients, namely those with cirrhosis or chronic hepatitis B, adhering to the planned schedule if possible. However, a delay of 2 months is acceptable after discussion of the risks and benefits of delaying surveillance with the patients. However, in patients with increased risk of hepatocellular carcinoma, such as those with elevation of alpha-fetoprotein or presence of liver nodule, should be prioritized for HCC surveillance. I thank you for your attention. And before I end, I would like to invite you, on behalf of the Malaysian Society of Gastroenterology and Hepatology, I'd like to invite you to the Asia Pacific Digestive Week 2021. It will be held in Kuala Lumpur from the 19th to 22nd of August 2021. I hope you will save these dates in your calendar. I look forward to meeting you in Kuala Lumpur. And if you would like to meet us earlier, we have the annual scientific meeting of a society, Virtual Guide 2020, bringing the future of to you. And this will be held on the 27th to 29th of November 2020. Thank you very much for your kind attention.
Thank you, Dr. Tan Suk Siam, for the enlightening us of the current scenario of the hepatocellular carcinoma, in particular in Malaysia setting. And I'm sure it's more or less the same like in Philippines. And we're going to have a second presentation by another outstanding speakers. We have with us today, Dr. Hiroyuki Yamada, or Dr. Hiro. Dr. Hiro obtained his bachelor and master and doctorate PhD degrees in Tottori University in Japan. And he's a very experienced scientist and has been working with Wako for the last 2 decades or so. And he is a very active member and producing a publication in many to date. And he's also a member of the American Clinical Chemistry, Microbiology, and American Society of Clinical Oncology, as well as American Society of Study for Liver Disease. At the moment, he's a global clinical research manager with the Fujifilm Wako Pure Chemical Corporation at the Department of the International Sales and Marketing. And it's a great pleasure to have Dr. Hiro today, and he's going to talk to us about the introduction of HCC biomarkers and its clinical utility. Dr. Hiro, the stage is yours.
Thank you, Professor Afendi, for kind presentation, introduction. Good afternoon, everyone. Here are my agenda for today's presentation. First of all, I would like to introduce the current practice and benefit of HCC surveillance in Japan. As Dr. Tan said that early detection of HCC is very important because curative treatment options are different. If tumor size is less than 3 centimeters, patient can receive curative treatment, such as resection, transplantation, and RFA. But if more than that, patient cannot receive curative treatment. So how doctor can detect small tumors? HCC surveillance for HCC risk patients is important. As Dr. Tan said that the higher risk patient needed HCC surveillance. Cirrhotic patient, HBV, NAFLD, and NASH, even though without cirrhosis, need HCC surveillance because the HBV and NASH without cirrhotic patient can develop HCC without going through cirrhosis. This is the guideline for HCC surveillance in the world. APASL, APASL is for Asian countries, and APASL recommends AFP alpha-fetoprotein plus ultrasound every 6 months. But Japan, JSH recommends 3 HCC biomarkers, AFP, AFPL3, and PIVKA II plus ultrasound every 6 months, 3 to 6 months. This is the guideline. And again, in the guideline, surveillance, ultrasound plus triple biomarkers, AFP, AFPL3, and PIVKA II for super high risk group every 3 months, and high risk group for every 6 months. This is very interesting experiences in Japan, as Dr. Tan briefly explained. More than 40 years ago, percentage of screened patients was 50%, just 50%. At that time, median survival in months was 3%. But currently, from 2001 to 2013, percentage of screened patients is 76.8%, and then median survival rate in months is 52 months, even though median age is 70 years old. So that means that HCC surveillance improves the patient's survival. But how can do for surveillance? So this is the data for the performance of ultrasound. As you can see, the performance of ultrasound is depends on the study, even though overall sensitivity is 60%. Because the performance ultrasound is depend on operator technique, ultrasound instrument, and human body size. So ultrasound is not enough for HCC surveillance. This is another publication from the United States. Sensitivity of ultrasound itself is 40%, 45%. Even though plus alpha-fetoprotein, still 63%. So ultrasound plus alpha-fetoprotein are still not enough. Therefore, 3 biomarkers plus ultrasound together is very important for surveillance to detect HCC. From this side, I want to explain about biomarkers for hepatocellular carcinoma. First of all, this is alpha-fetoprotein. As you know, alpha-fetoprotein is not liver cancer biomarkers. This is general cancer biomarkers. And low over sensitivity and specificity. Therefore, AFP is basically not specific biomarker for HCC, and low sensitivity and specificity, especially for early HCC, and better performance of late stage of HCC. This is another biomarker which called PIVKA II, same as DCP. PIVKA II is abnormal prothrombin, and more specific biomarkers are specific for HCC. And this biomarker is already cleared by US FDA, Health Canada, and CE, and JFDA, and all Asian authorities. And this is the AFP-L3, an isoform of alpha-fetoprotein with reactivity to LCA. So you can see the two structures of AFP-L1 and AFP-L3. And right on side is AFP-L3 has the fucose. And this fucose sugar change is strongly related to HCC. Therefore, AFP-L3 is more specific biomarker for HCC, and it's important to measure AFP-L3 to detect small and early HCC. So this is the trend of biomarker elevation. You can see the red line is for AFP increase earlier, and PIVKA II and AFP graduate increase gradually. This machine is a Mutas Wako, Microtas Wako I30, and AFP, AFP-L3, and PIVKA II is applicable for this machine. In this machine, all of required immunoassay steps will be done in one chip, microfluidic chip. From this slide, I want to share the clinical utility of 3 biomarkers. And this publication from the United States is showing using 330 HCC cases and 108 controls, including HBV as a majority, and 20 of 30 has less than 3 centimeter early HCC and single nodule. From this population, sensitivity of FPL3 DCP itself was 70% and 83%. And if you combine 83%, and specificity is more than 90. But more interestingly, at the bottom of the table, FP less than 20 nanogram per ml, this is less than cutoff, but still FPL3 and DCP detect 50% and also 40% if you combine 75% with the high specificity. So combination use of AFPL3 and PIVKA II improved early detection of HCC. From this study, we found 3 interesting cases. And case 1, just elevate, we can see the elevation of FPL3 before 9 months before diagnosed CT MRI. And from case 2, FPL3 and PIVKA II elevation 25 months before diagnosed CT or MRI. And case 3, only PIVKA II was elevated before diagnosis CT MRI. So HCC, hepatocellular carcinoma, is hepatogenesis. So adding FPL3 and PIVKA II to surveillance is very important. And this is another publication using 74 patients, HCC patients. And sensitivity of FP itself was 61%, FPL3 66%, and DCP same as PIVKA II was 40%. But if you combine sensitivity up to 91%. So again, combination use of 3 biomarker FP, FPL3, and PIVKA II is very important, improve more early detection of HCC. And this is the most current publication from Korean group for HCC biomarkers. So sensitivity itself was just 48%, but addition of FPL3 and FP improved sensitivity up to 94%. And from this slide, clinical utility for prognosis recurrence after treatment. So this study is coming from Toranomon Hospital in Japan, and using the 93 patient sample who received resections. And you can see if FPL3 value after resection was more than 5, cutoff, recurrence rate is higher. So that means that more careful follow-up might be recommended to detect recurrence. And this study from Ogaki study showing that this study was from Ogaki Hospital in Japan. And the sample were collected from HCC patients who received resection, Alpha test, total 270. And if the FP value before treatment was more than 5, and survival rate is much lower. So again, more careful treatment option and follow-up after treatment might be recommended to have better survival rate. And this is interesting cases, 2 cases, before after treatment. The case 1, at the diagnosis, only FPL3% was more than cutoff. And then you can see the small tumor by CT. And after treatment, the biomarker decreased from 30.4 nanogram per ml down to 0.5. This is less than cutoff. And case 2 also showing only elevation of FPL3 9.4% after treatment and 9.4 down to 0.5. So this means FPL3 is more useful for the patient follow-up after treatment. So this is a summary of clinical utility of HCC biomarkers. So HCC biomarker is useful not only surveillance, but also diagnosis and prognosis follow-up after treatment. Our company is working on the model, including the 3 biomarkers, which called GALAD, including gender, age, FPL3, FPDCP, GALAD. And here is the calculation formula. And in this study, cutoff was decided -0.63. And using the PIVKA II assay, you can use the conversion factor for this formula. And multi-center study for the validation of GALAD was conducted using UK, Japan, and German cohorts. From this slide, GALAD in red line showing the highest sensitivity and specificity from each cohort, UK, Japan, and Germany, compared to individual biomarkers. So GALAD score is better than individual biomarkers to detect HCC and maximize the sensitivity and specificity. And this GALAD is not related to the tumor size. So this means that GALAD score is useful to detect earlier, smaller HCC. So GALAD score is already implemented in the 2 calculation websites. One is in Mayo Clinic in the United States, and another is Medicare for the medical professional. So this is the GALAD website from the Mayo Clinic. So you can put the information of age, gender, and 3 biomarkers, and you can easily get the GALAD scores and probability of HCC. And this is from Medicare. Again, you can put the information and get the GALAD scores. Dr. Luis Roberts from the Mayo Clinic also established the score GALAD plus ultrasound. This is GALADAS. And GALAD and GALADAS is very similar performance, but GALADAS with GALADAS, which is GALAD plus ultrasound, slightly better than GALAD. But again, 3 HCC biomarker is useful for surveillance and diagnosis and prognosis follow-up after treatment. So 3 biomarkers is very important to use. 3 together is important. As a conclusion, HCC biomarkers are useful for HCC surveillance program, early stage small HCC detection. Especially FPL3 is more useful for small and early stage of HCC and prediction of recurrence after treatment, and combined use of 3 biomarkers can help patient management in conjunction with imaging modalities. HCC diagnostic model, GALAD and GALADAS, including HCC biomarkers, improve clinical sensitivity and specificity. Currently, AFP-L3, PIVKA II, 3 biomarkers were approved by Malaysia MDA in 2018. And 3 biomarkers are currently available in Pantai at the PIVKA. Also, 3 biomarkers approved by Philippine FDA in 2019, last year, and 3 biomarkers are currently available at high precision diagnostics. So if you are interested in 3 biomarkers, AFP-L3, and PIVKA II, please contact to ChemoPharm. Thank you.
Thank you, Dr. Hiro, for the excellent presentation. And at the moment, I do not see any question from the Q&A. If there is, please do type, and then I will read out. Before we waiting for Q&A, I have made myself a couple of questions here. For example, I want to throw to the first question to Dr. Hiro.
Yes.
You mentioned about the triple markers, AFP-L3 and AFP and PIVKA or DCP. It's probably better to use rather than traditional alpha-fetoprotein plus ultrasound. What about the cost effectiveness? Because we are using 3 markers now, 3 sets of the blood tests, and we also need ultrasound. So does it cost effective to the patient?
Yes. So as you know, AFP is not specific biomarkers. So positive, false positive result from AFP makes CT or MRI cost. But using the AFP-L3 and PIVKA II together with AFP, even though ultrasound, you can minimize the false positive, and you can minimize the cost of CT and MRI.
Thank you. So what is the cost? I have a question here, Q&A. What is the cost of the 3 biomarkers together? Maybe this is a question for Yiping, really, yeah?
Yes. Regarding the cost, please.
Okay, so we leave to Yiping to answer later. So the next question is to Dr. Tan Sok Siam, that you mentioned, I think we all know that less than 5% of HCC patients when diagnosed required surgical or chemotherapy, and majority actually are very poor or very late stage. Is it because awareness to be screened is not there, or is it surveillance strategy that we use 6 monthly liver ultrasound and alpha-fetoprotein did not catch the super high risk patient, or is that we are missing a lot of this plastic nodule that change to HCC, for example? So what's your comment on that?
Thank you, Effendi, for the question. It is a very important question for us in Malaysia. Certainly in my practice, I do see many patients who come in with BCLC stage D, for palliation, because mainly, in any disease, we have to have awareness in the public and the healthcare professional to make the diagnosis, use the modalities for diagnosis and treatment to effectively bring down any burden, morbidity or mortality of any disease. So in my practice, I see a lot of cases who come in with symptoms, abdominal pain, and the abdominal pain was due to large HCC, and the cause was found for the first time, either hepatitis B or hepatitis C. So we are going the other way around. The patient presents with complications, and we make the diagnosis back to the cause. That is one. In terms of surveillance, I think it could be improved. It could be improved in terms of trying to get the disease earlier, as Dr. Hiroyuki was mentioning, so that patients can be treated with better curative treatment and give us a better survival. Certainly a lot of work to be done, Professor Effendi, and all of us.
Thank you, Dr. Tan. And I'm going to ask to Dr. Hiro again.
Yes.
I like the Gallup score you mentioned just now. Look at the gender, age, and L, and so. But in that one, it does not include the etiological diseases that possibly drive the HCC, meaning that you take all the causes of chronic liver disease as a pulling factor to have a HCC. Is the markers AFP-L3 or PIVKA, are they sensitive more, for example, to HCC or NASH or Hep B or autoimmune hepatitis? Do they actually useful for the selection of cirrhosis because of, let's say, HCC is far better using the triple biomarker as opposed to HBV or NASH? Because if you throw over the whole liver cirrhotic, again, regardless of the etiology, in 20, 30 years' time, you'll be like alpha-fetoprotein 2. So, and the sugar that you mentioned there in terms of signaling pathways, in what specific chronic liver disease that really useful for us to apply these triple biomarkers to screen for HCC? Comment please, Dr. Hiro.
Thank you for a great questions. Actually, FPL3 and PIVKA II is the specific biomarker for HCC, hepatocellular carcinoma. So that means that they are not increasing in patients with chronic hepatitis. But as Dr. Tan and Prof. Effendi said that NASH and HBV has more risk to develop HCC. So in order to detect small tumors from just developed from late stage of fibrinosis or cirrhosis, using two biomarkers, you can detect. And early detection, small tumor detection help to make curative treatment.
Dr. Hiro, if we look at the transformational process of liver lesion to cancer, if you look at the NASH or MUFL, they probably inflammatory driven HCC. If you look at Hep B and Hep C, a viral driven HCC. So clearly these two may affect the utility of the biomarkers, plus also autoimmune hepatitis, hemochromatosis, and other form of chronic liver disease, for example. Can you comment on that?
So I am not specialist for your questions, but based on our data from the study, so the publication which I show you today is mainly for hepatitis B, and alcohol as etiologies. But last year, European group evaluated the rat model using the patient with NASH and NAFLD, and the performance of this cohort is similar, almost same as the previous publication. So that means that the GARAT performance is no differences between etiologies.
So that means the GALAT performance can be used the whole spectrum of chronic liver disease causing cirrhosis.
Yes.
Now, a question here, was there difference in sensitivity and specificity for 3 biomarkers for different etiologies of liver disease? I think you have answered already, including the MUFFLE, which is a new terminology for induced HCC. You want to comment further, Dr. Hiro?
So sorry, I couldn't hear you. The last
one question asking you the differences in the sensitivity and the specificity of these 3 biomarkers for the different liver diseases causing HCC, either MUFFLE or NASH or hepatitis B or hepatitis C. Are the big difference of the sensitivity and specificity?
Okay. So thank you for your questions. Basically, the performance of GARAT with hepatitis or NAFL, HBV, HCC, HCV, no different. But sensitivity of 3 biomarkers a little bit different. So for AFP-L3, is higher sensitivity for early or small HCC, but AFP and PIVKA II is more late stage.
Thank you. Dr. Hiro, I also like the sugar link that you mentioned early on. So for example, if NAFL or MUFFLE or NASH induced cirrhosis, in the case of patients with metabolic syndrome, including type 2 diabetes, which involve gluconeogenesis, do you think that is probably the best scenario for liver cirrhosis that we can use these triple biomarkers?
Thank you for your question. We don't have the data, but I really like your ideas. Yes.
Dr. Tan, we saw the survival from patient in Japan back in early 60s to mid-2000, 2013, that survival from 2 months to 52 months. And obviously about the treatment modality or screening strategy may also be the important factors for increasing survival. So we know that the diagnosis of HCC is about biomarkers and imaging. So extremely rare people do the biopsy, take the sample to diagnose HCC because it can be diagnosed by radiology and biomarkers. And because of this, the treatment or the chemotherapy development of the HCC, personally, I think may not be the same like other solid tumors that we got the sample from, let's say, colon cancer, lung cancer, other solid tumor, sent to the lab so the scientists can play around and come up with the inhibitors or markers. Unlike liver cancer, the chemotherapy development is not as good as other cancer. So do you think in Malaysia, survival is still low, not as good as in Japan because of availability of the treatment or poor surveillance adherence among patients, or knowledge, attitude, practice of clinician towards screening is still suboptimal? Love to hear your comment. Thank you.
I'm very sorry. The prayer is at the background. You can hear that.
Okay, you can mute first. I can ask Dr. Hiro first.
Okay.
Okay. Dr. Hiro, I can see roughly, I don't have a published data in around 100 or so my HCC patient, and those who get metabolic syndrome, diabetes, dyslipidemia, and obesity, these are the people in which the alpha-fetoprotein not typically more than 1,000. They can be mildly elevated, and they don't have a trending of increment of alpha-fetoprotein. And then bang, they're coming with HCC. So maybe there's a role of this subgroup of patient that the triple biomarkers can be used even though their alpha-fetoprotein is normal on many occasions, or did not show the increment trending of that. What's your comment on that?
Yes, I agree with Professor Afendi. Yes. And also, Japanese hepatologist is seeing the trend of the biomarker elevation. So it's important to compare the previous result. That's also a good point. Thank you very much.
And can I ask Dr. Hiro, while waiting response for Dr. Tan, about for example, factors such as duration of liver cirrhosis, does it influence the level of triple biomarkers? If someone got cirrhosis for 25, 30 years, as opposed to short duration, of course, we don't know the exact duration when the ultrasound tell us, or the fibroscan, but do you think the duration influence the level of triple biomarkers that you mentioned early on to catch early onset of HCC?
So actually, I have heard from the doctor in the United States, and he mentioned that the FPL3 is specific for aggressive HCC. So that means that just before HCC and after HCC, I think quickly, the situation is getting worse. So that kind of the aggressive HCC, FPL3 is the best markers.
Yeah. I mean, the other factors that I might think of is how good is the control of that diabetes patient, the level of HbA1c, because they glycolated hemoglobin, part of the sugar gluconeogenesis process, may affect the level of triple biomarkers. If you get anemia and low HbA1c, or no anemia and HbA1c is high, so they may influence the triple biomarker, may not alpha-fetoprotein alone. What's your comment?
Yeah, this is very interesting. This is very interesting. So we have never seen the comparison of the biomarkers, even though from the metabolic. So it is very good. I think the good data we can have.
I think Dr. Tan Sok Siang finished her prayer. We can listen her comment now.
Yes, yeah, so sorry about that, Sandy. So I think what I've said in my slide, to effectively trying to reduce the mortality and improve the outcome of patients with liver cancer, it is based on we need a multi-pronged approach. It does mean that we need to have the resources to also increase our ability to detect HCC early, and resources for curative therapy. And first of all, prevention is better. So diagnosis of viral hepatitis is very important, and good management of viral hepatitis, providing very good surveillance so we can detect cancer early. And when it's detected early, we should have multidisciplinary approach, giving the best treatment we can afford in a cost-effective manner for these patients. So MDT for HCC is actually vital, which is lacking in my hospital. I don't know about your hospital. And that is basically you know, we kind of have the tools. We need to how to use the tools better and more cost effectively. Cost is a huge issue as well in Malaysia.
Thank you, Dr. Tan. As a clinical hepatologist, so if you have a liver cirrhotic patient, whatever etiology is that, and ultrasound just say that stable cirrhosis and alpha-fetoprotein not trending, increasingly trending or within normal limit, less than whatever 5 of 10, you suspect that it could be HCC, and you do the triple biomarkers and slightly elevated, will you refer this patient for the CT for 3-phase or 4-phase liver, Dr. Tan?
Yeah, actually, for us, in a cirrhotic liver, when we have any inclination of possible HCC, be it a weak nodule or a raised alpha-fetoprotein, we immediately do jump and escalate our diagnostic test. We can go for CT scan or MR pre-morbus, and we go from there.
Dr. Hiro,
the GALAD and the more biomarkers is not available in my hospital, and I don't know, maybe cost will be an issue. So if we have it, that would be great.
Okay. Dr. Hiro, last question to you from me. It looks like me or asking you to the question today. Do you notice any difference of the triple biomarker for the child PU A, B, or C chronic liver disease, regardless of the etiology?
So basically, child PU is not late stage of HCC. So again, FPL3 increase from the patient with child PU, but for FP and PIVKA II, maybe late stage, that means B and C. I can check the data, and I want to check the data in detail.
I think we are 4:30 now. I think we are overdue for 10 minutes. And we thank you so much for the 2 outstanding speakers, Dr. Tan Soksiam from Selayang Hospital in Malaysia, and Dr. Hiro from Tokyo in Japan. And delighted to have a good discussion about these emerging biomarkers that we all of us can use in part of daily practice to detect a cirrhotic patient for HCC. And I pass over to Yiping. Off to you, Yiping. Thank you.
Thank you, Prof. Effendi. I would like to inform again, actually the test is right now available at the Pantai Premier Pathology starting 1st September onwards. So at Philippines, it will be at high precisions. So if you have further inquiries regarding the test, feel free to contact the below, contact number, and then we will actually will PM you directly on some of these questions from you. So thank you so much for everyone here. We would like to actually express the highest appreciation to MSGH, Pantai Premier Pathology, and Fujifilm Wako for the invaluable support. It has been a great experience working closely with these distinguished speakers. And once again, on behalf of Chemopharm, thank you very much to everyone. Have a good evening.
Bye-bye.
Thank you.